culture about 2 cc of the sample, total injected 2 cc.
Yes, sir.
My question is to Dr. Das. Thank you for this really interesting subject. It's good there is a place for decompression without fusion in body or systems. You mentioned the stability is either sliding here or still around its angle. We want to know, there is a limit. You say this is just for decompression and this is decompression and fusion. I mean, how much is sliding, how much is the angulation, and is there a normal angulation, inflection, extension, or no?
Yes,
You have a limit, you have a normal value, you have a score to decide this and this.
There are multiple studies about the limit of physiological normal stepping. Most of the studies differentiate the stepping according to the level. Most of the level above the applied S1, they accept normal stepping to 3 millimeters. And after that, it is abnormal or it is associated with compression. In the investigation, it is considered pathological stepping. Most of the study reached the number of 4, and number 4 stepping is accepted and it is within the normal range of motion, and that cause more further compression on the cord or the wrist. And the lower level of 5S1, they reach to 3 millimeters. And 3 millimeters stepping is within normal, and after that, it's considered abnormal.
This is flexion, extension, with weight, without.
This is in both of you, whether destruction compression or flexion extension.
The angle or the millimeters must be the same. Flexion and extension, you mean?
No. Flexion extension, just we get an idea about the stepping angle, which is usually positive, not considered to be a negative. It is normally positive angle. When it is changed to negative, that means there is posterior angle defect, and the angle changing, especially in flexion position, while in extension position, the angle is increasing. And we saw in our patient, those who are associated with bilateral bars defect, the angle is increased in extension, and it is changing to negative in flexion. Okay? While the level of stepping is changing from different level. Above considered 4 millimeter and 5S1 considered 3 millimeter.
Yes, sir.
The same subject, my teacher was talking about. The intraoperative measurement of instability. How would you do it? You say sagittal movement. I can measure it intraoperatively. How?
Yes, when we just discover and healing the paravertebral muscles, we do just a test by sagittal movement of the spinal process above and spinal process below, the stepping vertebrae. When we do sagittal movement, we saw a lot of
How much this about? Because in every discectomy,
yes,
I do the same procedure, and I find it 100%
but not
without spondylosis.
not much movement.
How much?
And
every disc surgery, I will do this
yes, there is
sagittal
normal
movement, and it is mobile.
normal range of movement.
How much? How
We
much? How much normal? Yes, how much?
determined it in the previous preoperative X-ray.
No, not the X-ray. Intraoperative measurement of stability. I am not talking about X-ray. I have seen it in 100%.
Yes.
There is mobile signal before cutting the line.
I agree with you. This movement is limited
Yes.
in normal
Yes,
subject.
or ordinary.
Normal subject, but it is excessive. We saw it's excessive in our
I mean, did you come across some measurement?
Is it clear?
Yes.
Please tell it. Is there any limit? Say 3 millimeter, 4
Yes,
millimeter?
measurement.
And your answer to him is, we don't know exactly. Don't procrastinate.
Yes.
So there is limit. Normally there is some movement. Normally, probably you can get this by experience. You can tell whether this is a physiological or
Because this
pathological.
will lead us.
Yeah.
Then we need, with simple disc excision, to use or
No,
not
no,
use.
it depends.
Yes.
There's an article from
Yes.
Finland. You know, sometimes they raise the flag that cliff should be done routine.
Yes.
And this is by Cloud, Allah yarhaman Cloud.
Routine after this.
ايه ابد
remove.
روتين كلاود يدعي انه كل فيلد باك سيرجري يساوي انستنس فيسوي روتين كليف. اجى واحد من فنلندا سوى ستنت قال لا اكو كيس بس سيلكت فاللي تفضل بيه دكتور عودي انه احنا we cannot take بس probably by experience you can tell that the movement is excessive or within physiological. بس أهم من هذا هي الفلوتنج لامينا. يعني if you find a floating lamina, this is highly suggestive. Yeah, of anesthetic. But to tell you precisely how much movement we haven't measured. Thank you.
Yes, Dr. Ali.
My question to Hadi, but he's not here, and I asked Dr. Ham. As we know, cardiac one is emergency. And the time is vital in treatment. Sometimes we're facing a patient, for example, he visited you and you ask him about the time of or duration of incontinence. And when he tell you this is 1 month or 2 months, okay, you tell him this is too late, no need for surgery. So when he came to me, he might try to put me in a trap. So can there is any indicator for us to know exact time or at least minimum? You understand my question?
Of course.
For example, he will call me just
Yeah,
2
okay.
days. Just 2 days.
Okay. Agreed upon that the earlier the better, particularly if there is mechanical blow to the canal. Okay, Ali? The earlier the better. But even if they present late, still there is a place for recovery. Okay, don't tell him that because you have lost your sphincter for 1 month, then whatever I do, I'm not going to cure it. But you say it like this. This may and may not. Okay? I'll operate on you, but I cannot guarantee you will be back to normal. But this may help.
Yes, but sometimes he might try to put me in trust because he will tell me that the incontinence just 2 days. But in reality, it's since
Well,
1
he
month.
can cheat you in many ways. It's not your fault. Because you have to depend on his saying. But to check whether he's liar or he's telling the truth, ask him the same question several times. Okay? Yeah. So ask him to come after 1 week. And ask him the same question. If he's a liar, you will check. If he's not a liar, but the answer for cardiac finding is the vascularity. The key for sex or prognosis is the vascularity. Our MRI, which is 1.5 or 1 Tesla, is not strong enough to tell you the exact nature of the vascularity. Nowadays, there is 5 Tesla and 3 Tesla, and they reach 7 Tesla. And by the 7 Tesla, they can tell the capillary circulation of the caudal. So if the capillary is blocked, no recovery. Don't bother yourself. But because we don't have this now, we have to give them chance. Follow the Torah.
But agree, even if it is, we have to be honest.
But protect yourself.
But I will tell you, I have 4 patients.
Yeah.
With cardiac climate, compression. 3 with 7 days, 1 16 days, 1 32 days.
Yes.
And surgery was very close.
Very good.
And 1 patient within the same day, he didn't recover at all.
So that the success is again
Yes.
is the vascularity of the caudal.
On the same day.
And the same problem, problem with spinal cord injury. Some patients improve, agree? Even without surgery, even without anything. And others, you do fixation, you do decompression, they don't do. And I think the key point is the preservation of the vascularity to the caudal.
Any other question, please?
Yeah.
What tell us about the surgery? hypersensitivity of the spine is a very serious problem. One of the most important.
It is a malignant disease.
One of the serious complications is the recurrence. How we can prevent the recurrence? Yeah, what are the measures which we can take in order to reduce as much as we can the recurrence? Yeah?
Nothing for the bone, just some tissue. Just some tissue for the bone. This is highly curable. Can be removed completely, but a lot of it is curable. Followed by chemotherapy also. But if it's involved the bone, so the only measure is to sensitive section. Is there any role for pharmacological treatment? There is a study to decrease the recurrence rate, but not curable by chemotherapy or but extensive section is very routine and our routine treatment. Our growth, there is a case study, but completed removal without using pharmacotherapy.
Yeah,
But
you know,
curable.
if it is not involving the bone, yes, there is a chance of cure. But once the bone is involved, the only way is to take the bone out, or you find it in the bone below around. So I can confidently say, hiatus disease of the spine is a malignant, and it carries a bad prognosis, and the patient should be warned, or should be informed in advance. Sorry to say, we are not going. Yeah, it carries very bad. مثل ما أحمد قال praziquantel, albendazole, tribendazole, of some help, but it will not eradicate.
Sometimes solved by amputation.
No, our leg is okay. But the problem is the spine and pelvis.
So the final. Okay, so at the last we thank our teacher and our professor Tamer Hamdan for his guidance for us, and we thank the speakers also for their nice talks. We thank the attendants for their coming and for their attention. Thank you very much.